Good evening, student friends. Today we are going to discuss in brief about shoulder dislocation. As all of you know, that shoulder joint is ball and socket type of joint which is formed by head of the humerus which articulates with glenoid fossa of the scapula. This is ball and socket type of joint. This is also synovial joint. The head of the humerus is 4 times larger than the glenoid fossa, and due to its larger size, the range of the movement of shoulder joint is more. Shoulder joint has flexion, extension type of movements, abduction, adduction type of movement, internal and external rotation of type of movements. So this is multi-axial joint and it has vast range of mobility, and this mobility that is more, the joints which has more mobility, they are more prone for dislocation. So 50% of the joints dislocated in larger joint, 50% contribution is of shoulder joint. This is also called as glenohumeral dislocation because glenoid and humeral head get dislocated from each other. So large range of movement at the cost of stability is the feature of this joint. This joint is stabilized by many structures. The first one is the glenoid labrum. The second, there are multiple ligaments. The third is rotator cuff, which is important structure which gives stability to the joint. This rotator cuff is formed by falling muscles, supraspinatus, infraspinatus, teres minor and subscapularis. So these are the 4 structures that gives stability to the joint. Biceps tendon also gives some stability to the joint. So the joint dislocation is not common with minimum force. So how dislocation is, what is the force that causes dislocation? This may be direct trauma or this may be indirect trauma like fall and outstretched hand. So the force is transmitted from this to this and shoulder joint gets dislocated anterior or posterior. So there are 3 major types of dislocations. Anterior, in which the head of the humerus gets dislocated from its original position in the anterior side, that is towards the chest. In posterior type of dislocation, this is rare type of dislocation which is caused by, in some cases with electric shock, in some seizure disorders, or when we give electroconvulsive therapy. This is also common. So anterior dislocation is common, posterior is not common. Anterior dislocation is common because the joint capsule is weak on the anterior aspect. There is third type of dislocation which is rare and rare. This is inferior dislocation of the joint. The joint gets down. This is called as inferior dislocation. If the head of the humerus is coming up anteriorly, it is called as anterior dislocation. If it is going back, it is called as posterior dislocation. And if it is going down, it is called as inferior dislocation or luxatio erecta. So whenever there is dislocation, the head of the humerus gets out of the glenoid cavity. So it may cause rubbing of glenoid labrum as well as head of the humerus. So there are 2 major lesions you should never forget. In recurrent dislocation or in acute dislocation, there is Hill-Sachs lesion. Hill-Sachs lesion is present on H, that is humerus head. H. Hill-Sachs lesion is present on the humerus head. It is present on the posterolateral aspect of the head of the humerus due to the rubbing of the head of the humerus. So this is called as Hill-Sachs lesion. Banker's lesion is present on the glenoid labrum of the glenoid fossa. So this is called as Banker's lesion. So whenever there is dislocation, the patient is in pain, the range of the movement is restricted, there is deformity, the deltoid muscle, it is not visible, it is flat because the head of the humerus has come anteriorly and the patient is in severe pain. So how we reduce this dislocation? The method of reduction dislocation is TI. Keep in mind, T is TEA. T means shy and followed by I. So T means you have to give gentle traction, then do external rotation, then do adduction. Elbow should be brought towards the umbilicus, followed by internal rotation. This is I. I means internal rotation. So our palm of the affected limb should touch the opposite shoulder. I will briefly explain it one more time. TI, that I am dislocated, this is a dislocated elbow, I am giving traction followed by external rotation. This is external rotation. then we are doing adduction of the shoulder, so that elbow joint should be towards the umbilicus, then internal rotation by touching the opposite shoulder. This maneuver reduces most shoulder dislocations. So this is TI. What are the complications when we get dislocation? Because dislocation is caused by major injury, it may be caused by direct trauma. So whenever the head of the humerus is dislocated anteriorly, posteriorly, or inferiorly, it can cause neurovascular structure injury, it can cause muscle injury, it can cause soft tissue injury. So what are the structures that are likely to be injured while shoulder dislocation? The first and most important structure is axillary nerve. It is most commonly in 37% of the cases this nerve is injured in shoulder dislocation. And how will you test this nerve? Axillary nerve, all of you know that it supplies deltoid muscle, so there may be sensation loss over the deltoid region, or the muscle may be weak, or deltoid function will be weak. In case of axillary nerve injury, there may be brachial plexus injury. In some cases, axillary artery and vein can be injured in shoulder dislocation, and the most common is soft tissue injury in the form of rotator cuff injury. We have seen that stability of the shoulder joint is due to rotator cuff along with other structures like glenoid labrum, rotator cuff, tendon of the biceps. So this rotator cuff injury is also common. As we know, when there is dislocation, there is severe pain. When we reduce the joint, the pain is less. After 4 to 5 days, patient feels very comfortable, and he don't follow the treatment, and he don't use the sling. Sling is the most important structure to give the rest to the joint. So in some cases, if the patients are not properly treated or inadequately immobilized for inadequate period, at that time there are chances of recurrent dislocation, and this recurrent dislocation is repeated recurrent dislocation. You get 4 times, 5 times, 6 times dislocation in 1 year, and that needs surgery. Most of the anterior dislocations, acute, they are treated with closed reduction and internal rotation, and in some cases we need surgery when there is associated fracture or associated lesions. So how will you investigate this case? In most of the time, the diagnosis is clinical. That on examination, we found deformity, painful distinction of the movement, the fossa is empty, the deltoid muscle is not visible, it is flattened. So we do X-ray. In some cases, we need CT or MRI. In some complicated cases, we may have to go for surgery in fracture dislocation of the shoulder joint. So this is in brief about the shoulder joint dislocation. This is useful video for undergraduates. So in brief, I will take the fast review of the shoulder joint in 2 minutes. So as explained, head of the humerus joints with the glenoid fossa of the scapula, and this forms shoulder joint. This is also called as glenohumeral joint, synovial joint, or ball and socket type of joint. 50% of the dislocations in body, the shoulder contributes 50% of the dislocations. There is large range of movement in shoulder joint because head of the humerus is larger than the glenoid fossa, and large range of movement at the cost of stability is the main feature of this joint. This joint is stabilized by a glenoid labrum, ligaments, and rotator cuff. Rotator cuff constitutes supraspinatus, infraspinatus, teres minor, and subscapularis muscle. Types of dislocation, there are 3. One is anterior, another is posterior, and third is inferior, that is called as luxatio erecta. So mechanism of trauma is direct trauma or fall on the outstretched hand. There is Hilsa's lesion which is present over the head of the humerus on the posterolateral aspects, and there is Bankard's lesion which is present over the glenoid labrum. It is caused by dislocation itself. While there is dislocation, it gets rubbed. So method of the reduction is traction. T means traction, E means external rotation, A means adduction, and I means internal rotation, so that the shoulder joint of opposite side is touched with the palm. This is most important method for reduction of the shoulder joint dislocation. Complications: arterial injury. Which artery is common injury? That is axillary artery. Vein may be injured, that is axillary vein. Brachial plexus may be injured, then axillary nerve is injured. So 3A you have to keep in mind: axillary nerve, axillary artery, axillary vein can be injured. Brachial plexus, the second is B, that is brachial plexus injury is common. Then there is rotator cuff injury. Recurrence is most commonest in shoulder joint, that is 40%, because the treatment may not be proper, and patient may have been using his limb after 1 week or 2 weeks. Ideally, it should be immobilized by 2-3 weeks, then followed by physiotherapy, and then patient should be told about the precautions. Don't do this. Don't do abduction and external rotation. It will cause recurrent dislocation in the future. So investigation, there are X-ray, CT and MRI, and treatment in some cases you may need surgery. Thank you friends for watching this video. Thank you very much.